You're watching Parker Success Academy Clinical Rounds with Dr. William E. Morgan.
Hello, I'm Dr. William E. Morgan, and this is Clinical Rounds, where we explore clinical insights for clinicians in the field. Today, I have a very special guest, Dr. Dana Hollingsworth, who's the Dean of Chiropractic Sciences at Parker University. Welcome to Clinical Rounds.
Hi.
So today we're continuing our series on the adjustment. And today we're going to talk about what the popping noise is.
The popping noise. It's not crack.
What's that?
It's not a crack.
It's not a crack. It's the audible, the cavitation, all these things we call it. But it really should be called tribonucleation. And I used to be a diving medical technician when I was in the Navy, and we essentially treated tribonucleation in the bloodstream, in the joints, the cerebral spinal fluid, and neuro tissues that basically you have gases expand as you come out from depth and bubbles are formed. That's tribonucleation. So, but when we adjust someone, we actually create tribonucleation. And the best way to describe it, if you can imagine a cylinder that is full of fluid and there's a piston and it opens up and there's more space than there is fluid. Well, fluid doesn't expand very well. So what happens, it draws gas out of solution and forms a little bubble. And if you hold it, the bubble will remain. You could do that with a syringe full of water, and you pull it out, you feel a little pop, a bubble will form.
So you're creating the bubble?
Yes.
Okay.
And it happens whenever you have a closed capsule, like the cylinder, and you expand it to the point where there's more space than there is fluid. That's tribonucleation. We see that, and there's a study that was done by Dr. Gotchuk and Frier, where they actually just did an MRI study, and you can see this on the screen, where they took a finger, a phalange metacarpal interface, and they just distracted it. And you can clearly see that dark spot there, a pop occurs. That's tribonucleation. And here's a schematic showing this as well. So what happens is you have a space, you can see the capsule, there's fluid inside. When you distract it out, there's more space than there is fluid. What happens?
You get the pop, you get the
the
bubble.
pop. Yes, and it'll sustain. If you hold it, it doesn't dissipate right away. So again, this is from open source from the research, and we'll cite it later on. So
this is similar to the cylinder you were describing. The joint capsule is acting like the cylinder. And then when you distract it, you're pulling fluid.
Exactly.
Gas, correct?
So one would ask, why is this important?
Yeah, right?
Yeah. So why is it important? What would you think is important?
Well, how have we explained the noise, the joint noise, for I don't know how many years now? It's like opening a can of soda, right? Gas release. And we've tried to find lots of ways to explain what it is. So I think this informs.
Yeah, I think there's a lot of anxiety with patients if they don't understand what's going on. But what's interesting, if you go back and watch this, again, I've heard somebody say that all adjustments are fast adjustments. I'm like, what are you talking about? Well, you watch it, it's slow ligamentous creep, but when the cavitation takes place, it's a sudden quickness to it. So there's the bubbles are formed, and this is what happens. So the study that we get this from, is that where it shows what's happening. Here it is. It's open source, and we'll put that there. Dr. Greg Gotchuk and Frier made this available, and it's available on Creative Commons. So it means anybody can go and look at this. So, and we're trying to come up with some ideas. One of the reasons I wanted to talk to you, Dr. Hollinsworth, is we want to make some patient education videos so that we can explain this, because there's a lot of anxiety of people.
Oh yeah. Especially about their necks getting adjusted or cracked, right?
Yeah, because it's
a lot of fear.
Yeah, and that bone conduction of it, it's
loud.
People, what's the word they say? You're breaking my neck. They're cracking things. I think if they understood that it's just basically opening space and releasing gas, probably nitrogen, there would be a lot less anxiety.
Yeah, I know there's some patients that love to hear that sound and attribute it to a successful adjustment. There's other patients that don't want to hear it, and then some people I don't think are attached either way. But I agree with you, there's a lot of fear and just anxiety around it.
I know a lot of chiropractors enjoy the sound too. And if you go to a seminar, you frequently will have, people really, if you get an adjustment from another chiropractor, they would want to make sure they got that.
They want that audible.
They want the audible. And it's not always a good thing. So I asked Dr. Cho on our own campus, like we have these ultrasound units, you know Dr. Cho.
Oh, yeah.
So if we could possibly look at something similar with using ultrasound, well, within 15 minutes, he got back to, and I'll show it now on the screen, these images, an ultrasound image of that tribonucleation. As you see, they distract the joint. That sudden pop, the white substance in there is gas. It's being pulled out of solution. So that's tribonucleation. That's the pop. That's the audible that we feel. And the bubbles are formed. Again, here's a little animation. And this is something we possibly could share to doctors in the field so they can put it on their website so they can explain to their patients what that is. You just simply distract the bones apart, bubbles formed, we release them, they come back. And Dr. Gregory Kramer from National did a study with MRI for lumbar facets where he put them into an MRI right after an adjustment, and they showed for like 15 minutes afterwards there's still an increased space between the facet, the zygapophyseal joints. So, but we're going to get to, again, a study that this aspect of triangulation, where the adjustment takes place. In the Navy, they use ships to hunt submarines. They have to have 2 points, that reference points of sonar to find the submarine. 3 or 4 or 5 or better, they get a better triangulation. We're using this technology with accelerometers to triangulate where the chiropractic adjustment takes place.
Yeah, this is pretty cool.
Yeah, we've listened to those researchers up in Canada talk about this. So what happened in that study that they used these accelerometers, and these doctors went ahead and try to find out how accurate we were.
Yeah, so my understanding for this one is they looked at the thoracic spine and also the lumbar spine and placed accelerometers on the patient in 3 locations so they could triangulate where the cavitation occurred, right? And they had the doctor take a contact, adjust a certain vertebra, and then figured out where the cavitation occurred. And you think it was on the same spot as the hand placement?
Well, spoiler alert. But it wasn't just, you put your hand over T6 and thrust, but did the doctor think that he got T6?
Oh, yeah.
Yeah, because they thought they got it.
Because they heard it.
Yeah. And we're not very accurate with that. So there's 2 ways to look at this. How would you look at it? So
they were within about a segment. So they weren't like, I adjusted the sacrum and got the neck. So that's good news. We're close. But we may not be actually getting motion and cavitation in the exact contact where our hand is placed. So I interpret this kind of 2 different ways. That the main way is that if you have a patient who, let's say you're really concerned about adjusting a certain area, but you want to move an area close. If we know that we might not be cavitating or moving the exact contact, the joint under our hand, I might choose to go a little lower, a little just farther away from that segment I don't want to adjust, because I don't want to accidentally impact that segment if I'm not intending to. So I think it's very valuable there. On the flip side, if you're trying to impact a joint or an area that's close by, but you'd rather someone's afraid of getting their neck adjusted, this could have great application there, right?
Yeah. So for me, how I look at it is if you're trying to get, and how I rate it is, if you're trying to get T6, you might get T4 or 5,
you might.
or T8,
you might.
But if you try to get T5, 6, and 7, you'll get T6.
It's true.
So if you try to get, and the reality of it, especially when you're looking, there's studies looking at it, the cervical spine, it's really hard to get one segment to release.
Yeah.
And we're not as accurate as we think we are.
No.
But you don't have to be to get the results. The patients get better even if you're not getting that particular segment to release. So again, these are data points. We talk about the research, but bringing the research forward, like we talked about the frictionless interface between the skin and the bones underneath it, so that you're not torquing things, and we're not quite as accurate. So what can we do to really still create a therapeutic effect?
We're still getting a good effect. We're still getting neurophysiologic change. We're still getting change in the body around the area that you add the impulse in. We're still getting motion. So it's not necessarily horrible that we're not cavitating or moving the segment our hand is on. It's good information to know, so you know what to do clinically, and maybe you should adjust the upper thoracic spine to help the cervical spine if your patient's afraid to have their neck adjusted.
There's certainly studies that show that
Right.
thoracic adjustments will help shoulder pain, thoracic adjustments will help cervical pain.
Yeah.
And something I'm interested in is people with cervical spondylotic myelopathy, people that probably shouldn't be getting an osseous adjustment can still get benefit by adjusting the thoracic spine. So here's another study that I think you're going to like. So we're not as accurate as we thought we were, but this study, the audible pop from high velocity thrust manipulation and outcome in individuals with low back pain. So it shows us that even if the joint doesn't pop, you'll get a therapeutic benefit from the force that's put through that segment.
So it's not the sound.
It's not the tribonucleation, the audible release, whatever we want to call it.
Yeah.
So today's segment, we talked a little bit. What is the pop?
Yep.
What does it mean? Are we accurate with where we're getting the tribonucleation, which we're not too accurate, but the good news is you don't need to be.
We're still effective.
We're still effective.
It's good.
It's the adjustment, not the audible.
Yeah.
So, anything else you would take from these studies?
I think this is, we need to focus on restoring motion, and we need to communicate to our patients about what the pop means or doesn't mean, the sound, and help them understand they don't need the pop to have a successful outcome.
I think that would be good. If we could create patient education information at Parker University, Parker seminars, and disseminate that to our constituents, those patients will, okay, I don't need the pop. Even if I did get the pop, it's not my bones breaking or all the things people think. Take away the negative outcome from it. We all, for those of us who've been adjusted know that it feels good and that you don't have that anxiety once you overcome that. But if someone comes to you, students, like, I couldn't get the adjustment. Yes, you did.
So that happens all the time with our students when they're learning. They didn't get the adjustment. They didn't hear the adjustment. And we always tell them, recheck. Repalpate. Did something change? What was your indicator before? Recheck it. Did you get change? If you got change, if there's motion restored, if you have more function, leave the patient alone. They're fine. You don't need the audible. In
clinical practice, I realize in my geriatric patients, of which I now participate in that group, I would not get that audible release, but I would get the pain relief, the relief of symptoms. And I realized, as my practice went on, I didn't need to swing for the fence. Didn't need to get a home run. That it was the adjustment, not the perception of I got it with the tribonucleation. Did you change the way that you talk to your patients though? So you kind of set them up so that they weren't needing to hear it? I didn't need to. I didn't need to. I didn't feel I need to. So there's all those patients that will tell you didn't get it. You didn't get it. You didn't get it. And once they're past a certain point, they've been to a bunch of chiropractors and they've been trained. They only got it if they can feel or hear that pop. Yeah. And how we overcome that? Well, we're an educational institution. I think it's upon us to create, maybe compile some of this data, try to figure a way to make it palatable to patients so that the doctors in the field can post it on social media or put it on their website so we can get the word out what we're really doing. Yeah. Creating change in neurology, right? It is. It's what it's doing. Restoring function. Restoring function, restoring normal neurological function, and it's pretty exciting. It's very exciting. And the mechanoreceptor aspect of it, which we'll talk in subsequent episodes, is really exciting from a neurological perspective. Yeah, absolutely. So, do you have anything else on this topic you'd like to share? I think I like what we were going with about just helping patients understand that's not a necessity to success, and helping, I guess, empower doctors that it's not the determiner of whether or not you got a successful adjustment. Dan. Well, thank you very much. Yeah. You've been listening to Dr. Dana Hollingsworth, and this is Clinical Rounds.
Thanks for watching another episode of Parker Success Academy Clinical Rounds with Dr. William E. Morgan.